Hi, this is Dr. Nick with the ECG Academy, and this brief lesson will be on accelerated idioventricular rhythm. The reason I say brief is because that's kind of the nature of this rhythm. It usually doesn't last more than a few seconds or a minute or so, and so it's kind of hard to catch it on a 12 lead. So I don't have a lot of examples of it. And in fact, it tends to be rather benign. People generally don't even have symptoms from it, but it is important that you be able to recognize it. Now, for one reason or another, accelerated idioventricular rhythms occur because of abnormal signals that arise from the His-Purkinje system, and sometimes the ventricular myocardium, but that's less common. They occur at rates of greater than 40 beats per minute, but less than 100 beats per minute. That's the rate that you'd expect to find it at. Now, how do you recognize it? It's not just the slow rate, it's also the appearance of the QRS complex. Because these signals are not taking the normal His-Purkinje system, you will not see a narrow QRS complex, but rather, like a PVC or ventricular ectopic beat, the signal travels slowly through cell-to-cell connections rather than over the rapid His-Purkinje system. And so the electrical signal takes a long time to get around the heart. And instead, what you see are these very wide, bizarre-looking beats that look like a PVC. But there'll be a whole bunch of them in a row. And in fact, they can be regular, but it can be sometimes a little irregular depending upon what's causing this disturbance of impulse generation. So these impulses are being generated abnormally by this abnormal focus in the heart. Now, this can be firing because of any number of reasons. Sometimes it can happen because of an insufficient oxygen supply, so it can be due to ischemia. Sometimes it can be due to electrolyte disturbances or drug overdoses like digoxin. But what you see is this continuous ventricular rhythm between 40 and 100 beats per minute. And you should generally see some evidence of AV dissociation. So the P's are doing their own thing, and they're often beating at a similar rate or maybe a little slower or a little bit faster, and it's common to see the two rates competing with each other. So here's an example. As you glance at the forest, you can see that the R to R intervals are fairly regular. And if you find a QRS complex that lands on a heavy line, this one comes close. You can read the rate as 300, 150, 100. It's a little over 75, maybe 78 beats per minute. But the QRS is clearly wide, and when you look in front of each QRS complex, you do not see a P wave anywhere. So you'd say, well, why isn't this just like some kind of junctional rhythm with a bundle branch block? Well, that is a consideration, but if you look very carefully at the T wave, you'll see that there is a P superimposed on the T wave, and here it is again. So there are P waves, but the time from the beginning of the QRS to the time of the P wave is a little long for these to be retrograde Ps. And when you look at where the P wave lands with respect to the QRS complex, you'll see that it changes. In fact, if you look down in V3, you can see the P wave is now just at the very end of the QRS complex. Compare that with this P wave, which is on the T. So what's really happening now is the sinus rate is a little bit faster than it was back in the beginning of the strip. And the sinus rhythm is now overtaking the ventricular rhythm. And in fact, you can see that this P wave and this beat is now gone. It's disappeared because the P's are catching up with the QRS's. It's like a time warp. Now the P here is sort of in the middle of the QRS, and now look at that. It's peeking out from in front of the QRS complex. So in this part of the strip, the atrial rate is accelerating, and it's starting to take over the rhythm, but it hasn't gotten there yet. If we were to continue to see this strip, we'll actually see P waves that come further and further in front of the QRS complex, and you may get a fusion beat, and then eventually the sinus rhythm will take over again, and the P wave will manage to get down the Purkinje system and give you a narrow QRS complex again. So basically you have two separate rhythms that are going on, and they're competing with each other. One is arising from the ventricle, and we say that because the QRS complex is wide, and the P wave that we see in the T wave is dissociated from it, so it's not a retrograde P wave. And then you can see that the atrial rate slowly accelerates, and eventually it's going to take over again. So as I said, it's kind of hard to find AIVR unless you're really looking for it, and it often doesn't last long enough to catch it on a 12 lead. More often than not, you'll see it on a rhythm strip. Okay, now I want you to appreciate that there are actually like 3 ways that AIVR can get started. You can have a sinus rhythm, and then what may happen is you may get a pause because of, let's say, AV block. Here the PR got longer, and then you have a block. Now what happens is there's such a long period of time that a Purkinje fiber decides to escape. It decides to fire as an escape beat. And now what happens if you march these P's out, the next P would occur right here, and it didn't get a chance to do anything. And so now you have this accelerated rhythm that's going on. And when does the next P wave occur? Well, it may occur here, and you might get a little blip of a P, but the accelerated rhythm is only a little bit slower than the sinus rate. And so eventually the sinus rate takes over, and then you may get a fusion beat, and then finally the sinus rhythm declares itself to be the faster of the 2 rhythms, and then you'll get a normally conducted beat again. In this case, the AIVR started as an escape rhythm because of a pause. The second way it can get started, if a Purkinje fiber starts firing in the ventricle, and it starts to fire just a little bit faster than the underlying rhythm, what you may get is a fusion beat here where the QRS is a little bit wider. The QRS starts a little bit earlier than it should because you don't get this PR segment. And then it takes over, and then you may wind up with some sinus beats that peak out from the other side of the QRS complex right here. And then what happens is usually the AIVR resolves and the sinus rhythm kind of takes over again. The last way that it can get started is with a PVC. So here's an example of AIVR that got started with a PVC. In this case, you have a sinus rhythm with a little bit of a first degree AV block. You have another sinus beat here, and these 2 strips are running simultaneously, so you can see the P waves very nicely here and here. And then what happens is the patient has a PVC, which you see in 2 different leads. The PVC, it's clearly a PVC because there's no P wave in front of it. It's wide and bizarre, looks clearly different from the underlying QRS complex. And in fact, you see a retrograde P wave that occurred after the PVC. But what happens is, after the PVC, what we generally see is a compensatory pause. And this is actually more likely to occur in someone who has sick sinus syndrome. Why? Because if you measure the P to P intervals, if you take a pair of calipers out and you bring it down to the P to P interval, take the onset of the P waves here, you see that these P waves are occurring at a rate here of, let's see, 300, 150, 175, about 70 beats a minute. But what happens is the P wave should occur here, but the PVC got in the way. And then you wound up with another P wave that kind of reset the sinus node. So now you have this very, very early coupled atrial event that was due to the PVC. It's a retrograde P, but it gets into the sinus node and it resets it. And in fact, because of overdrive suppression, the sinus node gets suppressed. It's almost like you get a post-tachycardia pause, even though the tachycardia only lasted for 1 beat. And so if you measure out, you see there's no P wave here. Why isn't there a P? Because I said the sinus node gets suppressed by this retrograde P, and you wind up with a pause. Well, that pause allows the AIVR to get started. So now the same spot where this PVC arose winds up firing again, here at a rate in the low 40s. So now you have set up this AIVR that's marching through at a rate of about 42 or 44 beats per minute. What are the P waves doing? Well, you can actually see one start to peak out right here. So right here, you see the sinus node is trying to come back from being suppressed by this retrograde P wave. So the sinus node is beginning to accelerate, and in fact, here you finally get a sinus P that's still a little bit slow compared with this P wave because it's just coming back from being suppressed. But it does conduct down to the ventricles with the same PR interval that you saw in the beginning of the strip. So this PVC set off this chain reaction that resulted in a brief run of AIVR because of suppression of the sinus node and slowing of the sinus rate, but then the sinus node finally came back and took over again. So as I mentioned before, it's often the 2 rhythms are competing with each other, And you can actually see AIVR sort of come and go, especially if the two rates are very similar. So it's a kind of a quirky arrhythmia, but you need to be able to recognize it and call it as such. Now, sometimes when AIVR gets a little faster, especially when it starts like this, with this sort of sudden onset, rapid rhythm, and let's say if it's a rate of about 90 beats per minute, a lot of people will call this slow VTach. And the distinction is difficult to make sometimes. People say that slow VTach is more regular and that it has an onset with a shorter R to R interval than the usual AIVR that usually occurs as an escape rhythm. In fact, it's probably the same mechanism, just a different rate and a different mechanism of onset. Clinically, you would treat it similarly. Most patients won't even feel symptoms, but if they do, you generally manage it conservatively. You don't run in there with a syringe full of lidocaine or anything. And it's usually self-limiting, and long-term therapy for this is almost never needed. Well, in the next video, we're going to be talking about ventricular tachycardia, the monomorphic variety in particular. And you'll see some of the same ideas of AV dissociation and wide QRS complexes because of abnormal interventricular conduction. But that's something you see much more commonly, and we're going to spend quite a bit more time on that. So for the ECG Academy, this is Dr. Nick. Thanks for watching.